We're going to give it just a couple more minutes, then we'll get started. And for those just joining in, this is being recorded. All right, we're going to get started in just about another minute. And again, for those that have just kind of joined in, this is being recorded. Also, you'll notice in the chat there are links. There is a link to the public notices website, and that's where you can view the agenda and all the other policy documents that are being revised. Okay, well, let's go ahead and get started. So good morning, everybody. And for the record, my name is Serene Peck. I am a healthcare coordinator and policy specialist in our behavioral health benefits and coverage unit with the Division of Healthcare Financing and Policy. Today, we'll be going over the changes for our psychiatric residential treatment facilities, PRTS policy in Chapter 400, mental health services. The goal is for these changes to be effective 2/26/25, as we are planning on a public hearing 2/25/25. Today, we'll review the overview of what a PRTF is and the various revisions to PRTF policy. We'll also be reviewing the basic outline of the new policy sections so that you can get an overhead view of how this policy is laid out now. Then we'll review the PRTF policy pages so you can all see the actual revisions. After this, we'll come back to this PowerPoint to go over some rates changes and the complex care definition. Following this, we could take some time to review any questions or comments you may have. So a PRTF is a secure facility, other than a hospital, that provides a range of psychiatric services to treat recipients under the age of 21 years on an inpatient basis under the direction of a physician. PRTF care is the most restrictive type of care and is used for treatment of recipients who have been clearly diagnosed as having psychiatric, emotional, or behavioral disorders that are so severe that the recipient is a danger to themselves or others and cannot receive services safely at the community level. The ultimate goal of the PRTF services is to promote a successful return of the recipient into the community. Revisions were done to align with federal requirements for PRTFs, including the additional requirement of obtaining the Centers for Medicare and Medicaid Services, CMS, PRTF certification, and to strengthen language to help support youth, families, and providers. Additionally, changes were made throughout the chapter to replace the language of RTC with PRTF. The prior policy had generally aligned with the federal requirements for PRTFs, except for its reference to RTCs and lack of specification regarding the need to obtain CMS PRTF certification. With the removal of substance use policy done to this chapter earlier this year, the PRTF policy is now within Section 403.7 instead of 403.8. Also, the layout for PRTF policy has been adjusted for clarity and is now 5 main sections instead of the original 3. These are titled PRTF Services, Coverage and Limitations, Provider Requirements, Eligible Recipients, Admission, Continued Stay, Elopements and Discharge, and lastly, Provider Responsibilities. Much of the original policy remains, but has been rearranged and language strengthened and revised accordingly to the new sections. So let's review these new sections. I will scroll through these following PowerPoint slides, which outlines the sections and subsections fairly quickly so we can get the draft policy up to review so you can all view the actual changes. And this presentation, along with the other policy documents, are also able to be viewed on our Public Notices website if you want to re-review this later. The link to the Public Notices website can be found in the Teams chat. So here's the basic outline for section 403.7, which is the general overview of PRTF services and discusses these 4 areas. Reimbursement when rendered in accordance with the section, a brief summary of what a PRTF is and who they provide services to, and that these policies are the same for recipients covered by Nevada Checkup, except where otherwise noted in the Nevada Checkup Manual. Section 403.7a outlines coverage and limitations. The subsections within this go over these following 6 areas: covered and non-covered services, arranged and concurrent services, reimbursement, non-discrimination, and therapeutic leave days, formerly known as therapeutic home passive. Section 403.7b outlines provider requirements for eligible providers regarding requirements that providers need to obtain to enroll or remain enrolled as a provider type 63, such as licensure, accreditation, PRTF certification, and letter of attestation. Section 403.7c outlines eligible recipients. This section goes over requirements a recipient needs to meet to be eligible to receive services for a PRTF level of care, such as age range, diagnosis, SED determination, CASI-LOCUS score, and that services for the recipient are not appropriate at the community level and instead require services on an inpatient basis under the direction of a physician. Section 403.70 is 4 main areas. These first 2 are for the admission process and continued stay authorization requirements. The actual process for PAR submissions remains the same as it always has been, except for some instances where a post-authorization can be submitted, which I'll be reviewing when we get to the actual policy revisions. The other 2 areas within this new section are for elopements and discharge requirements. These discuss what an elopement is and requirements should an elopement occur, along with what is needed when preparing for discharge, keeping in mind that discharge planning begins the day of admission. Lastly, we've got our new section 403.7e, which outlines the provider responsibilities requirements. Much of this used to be within the original 403.7b. Some newer topics include emergency disaster preparedness, fingerprint-based background checks, documentation or medical record requirements, and staff training. Okay, so let's move on to the review of the actual policy now. But before getting to the PRTF policy revisions, I did want to mention that the authority pages are being updated to add more federal and state regulation citations. These include the addition of 441.184 to these main CFR PRTF citations, which is the emergency preparedness requirements. Also added 42 CFR Part 456 for utilization control. This is requirements concerning control of the utilization of Medicaid services, along with Subpart G, since this is specific to the psychiatric services admission and plan of care requirements for individuals under age 21. Also added Subpart G to 42 CFR Part 483 regarding the conditions of participation for PRTFs related to restraint and seclusion requirements. Have also added the citation to the State Operations Manual. Chapter 2 provides guidance on CMS PRTF certification, as well as the Nevada Administrative Code for PRTFs. And then lastly, fixing the Nevada State Plan, Section 4.19a information to reflect the pages that relate to inpatient psychiatric services. And as mentioned earlier, throughout this chapter, any references of RTC or Residential Treatment Center have been revised to PRTF or Psychiatric Residential Treatment Facility. As such, revisions to the administrative days policy in Section 403.9a3b and the IMD attachment at the end of this chapter 400 are being revised to reflect this. Okay, so on to the actual policy. And if you'd like, you can pull up the policy documents from the Public Notices website if you haven't already done so, to see the changes yourself and re-review as needed. So here is section 403.7, which has been shortened, simplified, and rearranged for better clarity. The definition of a PRTF has been added, along with their intended function and ages they serve. The level of intensity of needs grid was removed. This information has now been moved to the new eligible recipient section. And this subsection D is language that had originally been in the prior policy for this section. 403.7a is still for coverage and limitations, but there are quite a few changes here now. Covered and non-covered services language have been expanded into subsections versus the paragraphs they have been for better visibility. Language was added to strengthen policy and provide clarity, and a PRTF CFR reference was added as well. Medications were moved from covered to non-covered, and ABA services were added to non-covered. There's a new section for arranged and concurrent services with definitions of these. And if these services are not part of the PRTF all-inclusive services, these may be billed separately and may require prior authorization according to their particular provider type requirements. Transportation was added to this section, moved up from where it had originally been in 403.7a7. And this first paragraph for reimbursement was moved up from where it had originally been in 403.7c9. And the rate negotiated language was removed, and more on this later when we get back to the PowerPoint presentation. And the second paragraph is new language regarding when recipients have MCO coverage, since prior authorization and reimbursement occurs through the MCO plans for these recipients, which has been effective since January 1st, 2022. Section 5 is new language for non-discrimination. The prior criteria for exclusion section was removed. This was simplified and moved to the new section 403.7d1d. Section 6 is still for therapeutic home passes. However, the language has been revised from therapeutic home passes to therapeutic leave days, and much of the existing language remains the same. The original main paragraph has been broken down into multiple paragraphs, with some language adjusted for ease of visibility and clarity, along with some rearrangement too. Information was added regarding documentation to be kept in the recipient's medical record for therapeutic leave days, both for when the recipient is leaving and when they return. All right, and then we've got section 403.7b. So this is now a new section for provider requirements. Much of the information that had been within the original provider responsibility section has been moved down into the new section 403.7e. So this new provider requirement section discusses the requirements for providers to become eligible to enroll or remain enrolled as a PRTF provider. Additional information has been included to expand upon the licensure requirements. In-state PRTF providers need PRTF licensure through HCQC, and we need the equivalent of this for out-of-state providers. Language has been added regarding documentation needed if the PRTF designation is not clearly stated on an out-of-state provider's license. And we still require accreditation. We've just added a PRTF CFR reference regarding this. And as mentioned earlier, we now require the additional step of CMS PRTF certification, which is obtained from a state survey agency. In Nevada, HCQC performs this. And I'm very happy to mention here too that the grand majority of our currently enrolled provider type 63s have obtained CMS PRTF certification, with several others in the process of obtaining this. So thank you to all of the providers who have gotten me the needed documentation to submit to the survey agencies to complete this process. And lastly, for this section is language regarding the letter of attestation, which used to be in the prior section 403.7 before. Language was revised and added regarding the PRTF CFRs, along with language for the federal requirement of having annual attestations submitted by July 21st or the next business day if this falls on a weekend or holiday. A new letter of attestation will also be required if a new person takes over the position of the facility director. A link to the template for this attestation form can be found on the Provider Enrollment Checklist website next to the link for the PT63 enrollment checklist. But I'll go ahead and I'll drop in some links to this for you guys as well really quick. Okay. Section 403.7C is the new section for eligible recipients, which discusses criteria to be met for an eligible recipient to receive care in a PRTF level of care, such as age range, diagnosis, and SED determination. And this is now where the CASI locus level 6 information lives. Language was added regarding recipients not needing an acute level of care or having symptom severity to such a degree where services cannot be attained at the community level and requires inpatient services under the direction of a physician. PRTF services are expected to improve or sustain without regression a recipient's condition. Section 403.7D is the new section for admission, continued stay, elopements, and discharge. Much of the information that had been in the original 403.7C authorization process now lives here. Prior authorization is still needed before admission to a PRTF, including when TPL exists, with certain exceptions. And it is in these cases only in which authorization must be submitted within 10 business days of the readmission. These are elopements, which we'll be discussing shortly, observation ER stays lasting longer than 24 hours, and a readmission of a recipient to a PRTF of record following an inpatient hospital stay, meaning where the recipient had been before needing to be admitted inpatient for stabilization. Language was added and adjusted regarding what is required on the PAR form itself, since this had been listed under the CON subsection in the prior policy. Language was revised for the comprehensive psychiatric assessment for clarity. And language is also revised for what the CON is certifying for the PRTF CFRs, including the team certifying the need for services. Subsection C and E were in the prior policy regarding the QIO vendor review of PRTF services for medical necessity and transfer requirements to an acute hospital should this be needed. And this subsection D is where the language from the criteria for exclusion was moved to and simplified, since all PRTF prior authorizations have always been reviewed on a case-by-case basis, and it is the PRTF's responsibility to ensure that their admission criteria and staff resources can safely clinically accept a recipient referral. Section F is clarified language regarding lateral transfer requirements, which is a transfer from one P263 to another, and are generally discouraged unless there is a valid need for this. And subsection G is also clarified language regarding retro authorizations for when eligibility has lapsed. For the continued stay authorization, subsections were rearranged and language revised and added to for clarification and strengthening of policy. These must still be submitted no later than a current PAR's end date, but language was added regarding the recommendation to submit current PARs in a 5 to 15-day window prior to the current PAR's end date. Subsections B and C are newer language regarding what the QIO-like vendor reviews and criteria used when making a determination of medical necessity approval to strengthen this aspect of policy. And subsection D is also new language regarding that lack of post-discharge plans alone will not be considered a valid basis for a continued PRTF stay. Please note that discharge planning begins the day of admission and should be reviewed routinely throughout the recipient's stay, with different discharge plans being ranged if the original discharge plan is not looking to be an option. Elopements is a new section. So this discusses PRTFs as being facilities that should be capable of preventing elopements, either through being a locked facility or being staff secured. The definition of an elopement and when it is considered a discharge is when a recipient is off the facility campus and out of line of sight of facility staff, no matter how long the duration. This then requires that the current PAR be indated and a new PAR submitted upon the recipient's return. And as discussed above in the admitting authorization process, in these instances, there is a 10 business day leeway to get the new PAR submitted. There is also language regarding requirements for what is needed when a recipient has eloped and later returned, and the need for a safety plan for repeat elopements, including whether a more secure placement is needed. The discharge section has some new language regarding permanency and stability within the community, being a priority for PRTF discharge planning, and the need to be including the recipient and parent guardian in the development of the treatment plan, with short and long-term goals identified as per PRTF CFR requirements. This includes the need for this to be updated in collaboration with the recipient and family guardian at least every 30 days, and the planned duration of overall services. Appropriate aftercare agencies and providers need to be identified, along with how they will address the recipient's needs for aftercare. Each referral will also include the appointment date and time, if known. The information regarding a full or partial denial based upon the review of medical necessity is similar information to what had been in the prior section 403.7C8. For the highlighted sentence regarding the appeals process, this was added after documents have been uploaded to the public notices website for this workshop, which was missed in including originally, but felt was important to include since prior policy within section 403.7C 7D discussed reconsiderations. But there's more to the appeals process than just a reconsideration. New language was added to the subsection regarding non-participation by the recipient or family guardian, along with not making progress, as being reasons why a full denial or partial denial for medical necessity would be received on a prior authorization request. In subsection D, the language regarding what a PRTF is to provide to the legal representative upon discharge is similar to what had originally been within 403.7B7, with some newer language added for policy strengthening and clarity. And then subsections E and F include language regarding the discharge summary requirements, including the need to submit this to the QIO-like vendor within 30 days of discharge, which was language that had originally been in section 403.7C7. So moving on to the last section, 403.7E. This is now where the provider responsibility section is that had originally been in 403.7B. So added language to the subsection 1 regarding PRTF providers needs to comply with other requirements within Chapter 400 that are applicable to all providers too. In subsection 2 is a new section for general PRTF service provisions, which discusses the need for an on-grounds education component, active family engagement services, parental involvement services, and need to ensure other aspects of care such as dental and medical treatment are provided. The medical language is similar to what had been in the prior 403.7B AB2. The information within the critical event serious occurrence reporting requirements is similar to what had been in the prior policy, with subsections rearranged and language that has been revised and added to for policy strengthening and clarity. This includes references to PRTF CFRs and notification of CPS if needed too. New language that was added was in regards to what information to include within incident report submissions. This includes the need to document in the recipient's medical record that appropriate agencies with names of the persons to whom the incident was reported to are documented and must be maintained in the recipient's record. Subsections C and D have been in the prior policy, but have been revised and added to for clarity and policy strengthening, such as imposing a ban on admissions and removing recipients currently at the PRTF if they are reasonably believed to be in danger. Emergency disaster preparedness is a new section and includes the PRTF CFR citation to refer to for further information. The quality assurance, quality improvement section was revised and added to from what had originally been in the prior QA/QI section 403.7B5 for strengthening and clarity. The fingerprint-based background checks is a new section in PRTF policy and is a requirement for employees within or contracted with from an outside provider to provide services to recipients in a PRTF. Section 7 and 8 regarding patient rights and federal requirements are essentially the same as they have been in prior policy. Remove the CFR references that have been in the original federal requirement section, since these are now sprinkled throughout PRTF policy and are included in the letter of attestation section, along with the authority section at the beginning of Chapter 400. The family visit section is also essentially the same as what had been in prior policy, including the requirement for the PRTF to be bringing up to 2 family members to the facility on at least a quarterly basis when the family resides 200 miles or more from the PRTF. And this includes the PRTF providing travel, lodging, and meals to the family. Documentation is a new section which discusses medical records requirements. This includes ensuring documentation supports psychiatric services that were provided, along with any medical, nursing, social, and other related treatment and care. These records include some of the following: evaluations, assessments, treatment plans, any doctor's orders, progress notes, critical events, serious occurrence reports, discharge summary, etc. In subsection C, for the highlighted 5 years, this was caught after documents were submitted for posting to the public notices website, but per DHCFP policy requirements discussed in Chapter 100, Section 103.13, all providers are to keep a record of services performed for a minimum of 6 years from date of payment for the specified service. So language will be revised before posting to the public hearing regarding this. Staff qualifications, the new section. However, much of the original language that had been within 403.7B8 was moved to this new section. And this did require some rearrangement of subsections, and new language was added too for policy strengthening and clarity. Some newer language is ensuring enough staff is in place 24 hours a day, 7 days a week, and that the medical director must be available on a regularly scheduled basis to support the program and conduct regular on-site in-person visits at the PRTF to assess the overall quality of care being provided. There is also newer language within the subsection C regarding the interdisciplinary team, including the PRTF CFR reference for this, and new language regarding the 2 monthly face-to-face one-on-one sessions and 24-hour availability includes this being able to be done by either a psychiatrist or a psychiatric APRN. And then lastly, staff training is a new section. This discusses types of training needed for PRTF employees, including documentation requirements. This also references PRTF CFR requirements as it relates to de-escalation and CPR training, which includes training in the use of non-physical and non-restraining intervention skills and safe and appropriate restraint and seclusion techniques, along with the ability to respond to signs of physical distress. Competency of certification in CPR shall be demonstrated and documented annually per PRTF CFR requirements. And other topics for training include these other areas such as patient rights, managing behavior, abuse prevention, suicide prevention, etc. And that concludes the review of the PRTF policy revisions. And as you can see, the rest of this is just the prior policy that is being struck out due to the new PRTF policy. We'll do questions and comments after the review of the last few PowerPoint slides. Okay, so as has been presented in prior workshops earlier this year on children's behavioral health services, plans for switching from cost negotiated rates to flat rates are being proposed with add-ons for facilities when they accept children under the age of 9 and/or children with complex needs. And this new $800 per day base rate and the additional $150 add-on for serving children under 9 and/or who have complex needs will be effective January 1st, 2025, pending federal approval. A public hearing for the PRTF state plan amendment regarding this will be held on December 30th, 2024. It is likely federal approval will be received after this date, and DHCFP will need to reprocess claims to reflect these new rates once federal approval is received. And in addition, PRTFs will have quality bonus payments tied to robust discharge planning, short lengths of stay, and successful community transitions and low readmissions. The goal is for this quality bonus payment to be implemented in the second half of 2025. And then this information regarding what would be defined as a youth with a complex care need will eventually be on the initial and concurrent prior authorization forms. And providers will need to submit supporting documentation with their PA submissions if it is felt a youth meets any of these criteria. And that is it for the PRTF public workshop presentation. So, are there any questions or comments related to anything that's been presented? Okay. And again, we're planning on the public hearing for these PRTF policy revisions on February 25th, 2025, with changes being effective February 26th, 2025. And yes, Ethan, I see your question. This is being recorded. I will have to double check if I'm allowed to send out recordings. But at the very least, I believe I can get you the transcript, but I will have to double check on that.
Serene will usually post the recordings to the YouTube channel. So once we get it, we can work with our public information officer.
Okay, perfect. I'll go ahead into if you do have any other questions. Oh, when will the new rate be approved? We're going to be having the public hearing for this on December 30th. So we're hoping to have this submitted out to CMS by, well, I think by, yeah, the next day, the 31st. And then that's going to begin the clock for the CMS review for that. So we'll hopefully have more information, within a month or two after that's been submitted. So, but we'll keep everyone updated on that as we know more ourselves. But yeah, so if you do have any other additional questions or comments, you can submit them to our behavioral health inbox, and I'll go ahead and put the contacts into Teams as well for that, as well as myself and then Lori and Sarah. All right. And then just lastly, here is some common acronyms seen throughout Chapter 400, just in case anybody wants to take a look at that. And I hope everyone has a great day and weekend and a wonderful holiday season.
Thank you.